participants, and good evening all the participants. Welcome to the Indian Society of Pediatric Neurosurgery virtual classroom for neurosurgery trainees. To introduce this program for a virtual classroom, this is a trainee-centered program. This will be run over a period of 24 to 36 months. The classes would cover the basics and advanced topics of pediatric neurosurgery through our faculty who are a part of the Indian Society of Pediatric Neurosurgery. And to give you a gentle outline, this is going to be an open forum. I mean, you'll have a teacher, you will have a self-assessment where the self-assessment will be based on that particular day's class. And then beyond that, there'll be an open forum for allowing you to clarify your doubts, your anything related to that particular topic. So again, I come back to the fact it's a resident-centered program. So it's you would have to help us in charting out how you want the program to run. And of course, towards the end, we will send you a Google survey form through which we will collect your inputs on how to improve the present venture. Thank you. I'm going to hand over to my co-colleague, who is Dr. Naveen, who is the education chair and who has created the scheme of the list of topics which are going to run across. Dr. Naveen, go ahead. Naveen, your voice is muted.
Yes, sorry. Yeah. Am I audible now?
Yes.
Yeah. Thank you, Suhas, and thank you everyone for joining us. I think we all know that the residency is predominantly, we have a lot of adult neurosurgery. And when you come out into practice and you see a lot of pediatric patients, and you feel that probably some of the things which we daily encounter in our pediatric practice are not covered during our residency. There are very few centers who have got excellent pediatric subspecialty, but there are few things which are missing. So this is an attempt by the Indian Society of Pediatric Neurosurgery to cover all aspects of pediatric neurosurgery, ranging from the basic examination of a neonate or infant to even the highest point, like the advanced tumor molecular biology and how to go about it. How to read an MRI of a neonate or infant. There are different myelination patterns, and we usually do not know much about that. So this is an attempt so that we know all about the pediatric, to get more idea about the pediatric neurosurgery. Second, what is the highlight for this program? So it's a resident-centric educational initiative, meaning thereby that this has got an educational goal in which the residents are the center, and what they want from us, this is what curriculum we have designed, what we thought probably might be useful for you, but you can write it back to us and say what more you want from us. As Dr. Suhas pointed out, there will be a feedback. You can rate us how it was, and you can give your opinion what you want from us. Secondly, it will have an MCQs, meaning thereby there's a self-assessment which will have 5 or 10 questions, which are the take-home messages from the whole class. What is the take-home message and what you should know from the topic? So what is the layout of it? So the entire program is divided into subspecialties, into subgroups, like a general examination. How do you examine a neonate? How do you see the child in a ICU? It's very simple. What is the analgesia you give for a neonate infant? How much CSF you drain when you put an EVD for a neonate? And for all this, we have an expert faculties. That doesn't mean that all the topics will be covered by neurosurgeon. Neurosurgeon will always be there, but it will have an expert faculty from the allied branches. Like when you want to examine a neonate, we have a pediatric neurologist with it. When you're dealing with the ICU, we will have an intensivist from the pediatric ICU, neonatal ICU, who will be delivering the talk on us. So how frequent it's going to be? It's going to be once in a month, preferably 4th Sunday, evening for 1 hour. The timings, depending upon how much it's with the residents, it can be adjusted, but then you have to let us know. And the course will run for approximately, as Dr. Suhas pointed out, for 24 to 30 months. So if you have any suggestion, please write to us as IndSPN, as IndSPN @gmail.com. So I think this is a brief outline about the program, what we have planned, and any suggestion from you is welcome. So without causing much delay, I will now invite Dr. Shibu to deliver his talk. And I think Dr. Shibu is a pediatric neurosurgeon and is a member of the Executive Council of the Indian Society of Pediatric Neurosurgery and works at Narayana Hospital, Bangalore. Over to Shibu.
Thanks, Naveen. So without further ado, let's get started. Shall I start sharing my screen?
Yeah, I think you can.
Can you see that?
Yeah.
And the whole slide is visible?
Yeah, I think Shibu, the whole slide is visible.
Okay. All right. Good evening, everybody. So today, the first talk in this hydrocephalus section will be about pathophysiology and classification. So our objective here is to understand how the various concepts in both hydrocephalus pathophysiology and the classification have evolved over the years, and to understand some of the recent concepts which have come up with newer investigation techniques, and ultimately to develop a kind of integrated understanding of the various forms of hydrocephalus in relation to the pathophysiology. And at the end of it, I'll take you through the slides once again and ask you questions in relation to those particular slides.
Voice is breaking.
So voices. So basically, hydrocephalus is defined as a disorder of CSF physiology, resulting in abnormal expansion of the cerebral ventricles, and is typically associated with an increase in the intracranial pressure. But what you must remember is that hydrocephalus itself is not a single disease entity. Rather, it's the result of multiple pathophysiological processes which can lead to this kind of a manifestation. Cushing's model of CSF circulation was one of the first to elaborate on how CSF is formed within the cerebral ventricles, goes out through the foramen of Monro and aqueduct, out onto the cortical subarachnoid space, and out of the cranium through the arachnoid villi into the dural venous sinuses and out. So this kind of circulation was something which he for the first time suggested, said that there is a continual movement in a definite direction through a highly specialized pathway that cuts across the blood circle to envelop an organ. So just like a lymphatic system within the brain, he described this kind of CSF circulation in a specific pathway. And he said this was also meant for carrying various metabolites across the brain. So this was in 1925. And along with that, around the same time, there was a lot of work being done by Walter Dandy. In fact, Dandy was one of the first to start a variety of experiments trying to understand what exactly is happening in hydrocephalus. And in 1919, he actually classified hydrocephalus into communicating versus non-communicating hydrocephalus. And this was based on whether a dye injected into the lateral ventricle could then be detected in the lumbar CSF through a lumbar puncture. So if the dye was detected, it was communicating. If it wasn't, it was a non-communicating type of hydrocephalus, according to this definition of Dandy. So this kind of terminology has often been confused with another terminology which was developed by Russell in 1949. According to this classification, it was obstructive versus non-obstructive. And this described obstructive hydrocephalus as something due to a blockage at any region in the major CSF pathway, including the ventricular cistern and the subarachnoid spaces, the cistern, subarachnoid space, all those kind of areas. So any blockage in this entire circuit was called obstructive hydrocephalus, whereas if there was no obstruction in this pathway described by Cushing, then it was called non-obstructive. So those were the initial ways to classify hydrocephalus. Subsequently, Harold Rickett developed a kind of mathematical modeling-based concept of hydrocephalus, in which he drew this circuit diagram, which you see on the screen, showing how CSF. Can you see my pointer?
No, Shibu.
Okay. All right, fine, doesn't matter. So you can see that at the top right corner, you have choroid plexus and CSF is formed there. Then it moves through the lateral ventricles, third ventricle, and a variety of a chain of, and each of those narrowing areas is what he said is a point or a focus of potential obstruction. So the first ones would be at the foramen of Monro, the aqueduct of Sylvius, then at the fourth ventricular outlet, then the space between the spinal subarachnoid space and the cortical subarachnoid space. And finally, before the cortical subarachnoid space, through the arachnoid villi, enters the dural. These are the points of obstruction within the cranial space. Outside, from the dural venous sinuses, it goes out through the venous sinus, through the skull outlet foramina, and there at the jugular foramen again you can have narrowing, which can also be a cause of this obstruction. In addition, on the arterial side, you have the circulation coming from the heart going up to the brain, and in between you have the cerebral microvasculature. So it's easy from our current understanding to extrapolate how obstruction of foramen Monro aqueduct fourth ventricular outlet can cause what he described as classified as obstructive hydrocephalus. But a little more difficult to understand was how the communication between spinal subarachnoid space and the cortical subarachnoid space, if that was obliterated, what would happen? And De Rocco showed that when this kind of a situation is actually present in patients who have normal pressure hydrocephalus, and in fact, patients with NPH who underwent shunt and had improvement in their symptoms, and then subsequently died due to other causes, when they underwent autopsy, there was significant arachnoid adhesions, which prevented communication between the spinal and the cortical subarachnoid spaces. So this is definitely something which we don't consider very often. The other point is what happens at the point where the cortical subarachnoid space goes into the dural venous sinuses. And if there is increase in pressure within the venous sinuses, or if there is an obstruction at the jugular foramen with rise in pressure within the venous sinuses, what happens? There are two kind of situations where this can happen. One is where you have an intact skull. So when this happens, the pressure starts building up within the cortical subarachnoid space, ICP rises, and in order to overcome the pressure within the dural sinuses so that CSF can drain out. This leads to increased pressure within the cranium, and this is often associated with a condition of idiopathic intracranial hypertension. The other situation is when the skull is not complete, and for example, if you have a situation of a child with a large open fontanelle, or the second situation is if you have done a decompressive craniectomy, say following trauma. So in these situations, what happens is the pressure within the venous sinus is high, and in an attempt to build up the pressure within the cranium, the the pressure within the brain starts increasing. But because it is in close approximation to the atmospheric pressure, it can never overcome that. And instead, what happens is, in small children, you have a condition called subarachnomegaly, or benign external hydrocephalus, where you have widened subarachnoid spaces, as well as you can have some increase in the ventricular size also. And in patients with a craniectomy, what you can have is this increasing pressure would manifest as obvious hydrocephalus. And that's how you get post-craniectomy hydrocephalus. Now, these are all situations where you have actual obstructions or regions where CSF is not able to flow correctly. But what happens when there is no such obstruction? How does that result in hydrocephalus? So one of the experiments done by De Rocco was to introduce a small balloon into the ventricles, and the pulsatility of this balloon was altered, and increasing the pulsatility, they found, resulted in hydrocephalus without causing any kind of obstruction. So change in pulsatility or the pulsatile environment within the ventricles without any obstruction can lead to hydrocephalus situation. And this kind of a condition is called non-obstruction or communicating type of hydrocephalus in this concept of Recate. In addition to this, to these broad definitions of obstruction and communicating, they modified each of the hydrocephalus based on etiology, the chronicity or the rapidity of onset, and the age of the person. Next, we'll come to another concept called cerebral compliance. And this, I think most of you would have already learned about this. And essentially, compliance is the mechanism by which the intracranial space accommodates increased volume without allowing the ICP to increase by either displacing one of the three CSF or blood out of the cranial cavity. So from the cranial cavity, CSF is pushed down into the spinal subarachnoid space. Thus, the volume of CSF which is pushed out can accommodate for an equal amount of intracranial volume without giving rise to increase in the ICP. Similarly, by venous constriction or pushing out blood from the cranial cavity, you can accommodate for some more increase in the intracranial volume without raising the ICP. So when you have a situation at the foramen magnum where there is either the tonsils are blocked off the exit of CSF, or you have excessive adhesions around the foramen magnum, then this option of CSF displacement is not available to the brain. And in addition, if the amount of blood volume has also been reduced, then you have a situation where compliance is steadily worsening. So what does this lead to? How is hydrocephalus connected to this situation? And this is the basis of what is called the hydrodynamic classification of Grice. It was additionally modified by another scientist, Proulx. And basically what it says is, on the one hand, you have acute hydrocephalus where there's intraventricular CSF obstruction. And on the other hand, you have chronic hydrocephalus. This is the result of a situation where there is decreased intracranial compliance, along with increased pulsatile pressure inside the brain. So every arterial pulsation within the brain is transmitted through the brain centripetally towards the ventricle. So from the skull, it's going towards the center. Now, when it reaches the center, this creates a force within the CSF, which has to be rapidly dissipated. The way this pressure is dissipated is out through the aqueduct. Or if you have made an ETV, it will go through the ETV. So now this is how the pressure, the centripetal force which is coming in due to the pulsatile pressure of the arteries gets dissipated. But if the compliance is low, each of these pulsations lead to a much greater pulse pressure, change in pulse pressure. And as a result of which, the amount of distending force increases. And the flow through the aqueduct, pulsation through the aqueduct is not enough to compensate for the increase in pressure, leading to an outward force which pushes against the ventricular wall and expands the ventricles. This, in turn, this kind of chronic hydrocephalus can again be of communicating type or an obstructive type. Now I come to another way in which hydrocephalus can be categorized. this was described by Shizuo Oi. And what he did was he divided the factors which affected hydrocephalus or the CSF physiology into patient factors, CSF factors, and treatment factors. And these three factors were then subcategorized into 10 subheadings. And this is based on which of these categories were involved. He described a multi-categorical hydrocephalus description. And this is the kind of form he used to fill up and classify each patient with hydrocephalus. So I'll quickly take you through each of these sections. So in the patient subhead, in the patient category, you have categories of onset. So was the onset of hydrocephalus congenital or acquired? Then the age of onset, is it in fetal period, neonatal, infantile, child, adult? Then you have the cause, is it primary, secondary, or idiopathic? Then is there an underlying lesion, such as is it a genetic kind of thing, that is a syndromic manifestation? Is it post-hemorrhagic, post-meningitic, post-traumatic, or is there a tumor, cyst, any mass lesion, anything else? Finally, the symptomatology in that patient. So relating to the head, whether it's macrocephalic, normocephalic, microcephalic, the symptom, is it occult, asymptomatic, symptomatic, or overt? Finally, the consciousness, whether comatose, tuberose, demented, retarded, and others. Is there a hydrocephalus Parkinsonian complex? Next, we come to the CSF part of it. That is divided into three subcategories of CSF circulation, in which you have communicating or non-communicating based on the description of Dandy. Then non-obstructive, obstructive based on what I told you about Russell's. Then you have where is the accumulation of fluid? Is it external, internal, interstitial? Is it just localized? Is it in the minor pathway? Or are there multiple isolated compartments? So this describes what has happened to the CSF circulation. Then comes the pathophysiology or the dynamics, ICP dynamics. Is it a high pressure system, normal pressure system? Then what is the chronology? Is it acute, chronic, long-standing? Is it progressive or spontaneously arrested? So all these things taken together describes the status of the CSF. Then comes the treatment aspects. So has a shunt been done? Is the patient shunt dependent or shunt independent? Has an ETV been done? Is it ETV dependent or independent? And such things. So based on all this, you get a complete picture of the individual patient, taking into consideration all the factors which can affect the hydrocephalus. So these are all the classifications which were based on the classic model of CSF circulation, which has been described more than 100 years ago by Cushing. But what are the evidences which support this kind of a circulation? And do they still hold water in today's day and age? So first of all, the first discovery was in 1875, more than 150 years ago, about 150 years ago, by Key and Retzius, where they demonstrated that CSF is absorbed by the arachnoid villi by injecting colored gelatin into the subarachnoid space of cats. The injection pressure they used was almost 60 millimeters mercury, which caused the gelatin to rupture through the villi into the lumen of the venous sinuses. And based on this evidence, they said that CSF is reabsorbed into the dural venous sinuses from the subarachnoid space into the venous sinuses through the arachnoid villi. So this was the experiment, which is what we base this assumption on. The second experiment was by Dandy and Blackfan. So what they did was they blocked the aqueduct of Sylvius in dogs and demonstrated that this could lead to hydrocephalus. After this first experiment in 1913, several people tried this experiment, and most of them unfortunately couldn't reproduce this. Then in 1970, Milhorat did an experiment in monkeys where he introduced a balloon catheter through the foramen of Magendie into the aqueduct of Sylvius and then expanded the balloon in the aqueduct. This again, with this he could induce hydrocephalus. So then comes the question of, so now the third experiment that Dandy conducted was to see where is this CSF coming from. So if hydrocephalus is resulting from obstruction in the aqueduct, he realized that it has to be something proximal to it. And the obvious answer was the choroid plexus. So the next experiment that he did was in a single animal, in a single dog, where he blocked both the foramen of Monro, and on one side, one lateral ventricle, he removed the choroid plexus, complete choroid plexectomy on one side, and on the other side, the choroid plexus was intact. So on the side with intact choroid plexus, he found that the lateral ventricles distended. On the side without the choroid plexus, there was a collapse of the ventricle. So based on this single experiment, he said that choroid plexus is the source of CSF formation. And this is how Cushing in 1925 put all this together and brought out his theory of CSF circulation, starting with formation in the choroid plexus, outflow through the aqueduct and fourth ventricular outlet, then out through the basal cisterns onto the cortical subarachnoid space and out through the arachnoid villi. So these continued to hold sway for a long time, as you can see, till several other studies started gradually piling up, suggesting that this may not be the real picture and that we need to look further and we need to study the issue in more detail. Regarding the experiment by Key and Retzius, a subsequent experiment by Weed in 1914 showed that if you inject the same colored gelatin in the subarachnoid space at a lower, more physiological pressure of about 9 to 13 millimeters of mercury, then he could not find the gelatin in the dural venous sinuses. Of course, this could be because the gelatin is much thicker than CSF, so we cannot 100% say that this completely rules out arachnoid villi as a source of exit. But definitely, the initial experiment was refuted at lower pressures. The other question was about where is CSF being formed. Hassini et al. In 1937 found that when he did an experiment similar to what Dandy did, he found there was no ventricular reduction on the side which had the plexectomy. Third question was about outflow through the aqueduct. So Dandy and Blackfan had shown that obstruction will cause hydrocephalus. Now what Oreskovic did in 2002 was he put a small cannula into the aqueduct. So this cannula was then brought out at the same level as the aqueduct. And in the horizontal position, what they found is that there is no flow through this tube. So CSF came and stood at the tip of the catheter and pulsated at that exit point. It did not flow. But if they put a catheter into the lateral ventricle and injected fluid, then active flow could be seen through this tube. So flow is possible, but only if there is increased CSF being pushed into the ventricles. In a natural situation, there was no actual flow across the aqueduct, only pulsatile flow, only pulsations. The second thing he did was he injected a high sucrose solution into the CSF. this again induced flow through the tube, suggesting that as osmolarity in the lateral ventricle increases, there is increased CSF production, and this suggested that osmolarity is a major influencer of CSF circulation. After this, there have been other studies using time slip sequences of MRI, where again they have been able to demonstrate no net flow across the aqueduct and only pulsatile flow at the aqueduct and at the foramen Monro, and absolutely no flow in the lateral ventricle itself. So time slip MRI has again changed our several of our concepts of how CSF moves within within the human being in a live human being. Then then this brings us to the overall picture of that Cushing was describing about how CSF is produced in the ventricles and flows out and then exits through the arachnoid villi. Does this hold good after all these other experiments? Another interesting study which Bulat et al. Did in 2008. So what he did was he, instead of the problem he said that was that when you use dyes into the lateral ventricle, because of the higher density compared to water, it automatically settles with gravity in the region of the aqueduct and then comes out. So demonstration of dye moving out through the aqueduct could merely be an indication of gravity working on the higher density substance. So what he did is, instead of using dyes, he decided to use 3H water. So that has one extra proton compared to the usual normal water. So it behaves in the same way as water. It has the same density. It reacts in every way like water. So this 3H water was then slowly put into the ventricles or the subarachnoid space of cats. And the change in 3H water within the microvessels and the sinuses was measured. Microvessels, so you have CSF getting injected into the lateral ventricles or subarachnoid space, and then we see what happens to the 3H levels in the CSF, in the arteries, in the veins. So initially when they injected this, they found that 3H water very rapidly is seen to accumulate in the veins, in the venous sinuses. Whereas very little, whereas in the CSF and in the arteries, the concentration remained stable. So their conclusion was that this 3H water very quickly and easily equilibrates across the microvessels. So the fluid within the ventricles goes through the ependyma or goes through the subarachnoid space, through the perivascular spaces, goes through into the interstitial space and gets quickly reabsorbed into the veins. So this happens so quickly and rapidly that the concentrations in the CSF and in the arteries never increase, and it's only in the veins that it rises. The same procedure was then done using 3H inulin, which passes poorly across the cerebral microvascular walls. So this is to contrast it with the 3H water, which was passing very easily through the microvascular walls. So now let's see what happens. So same infusion of 3H inulin goes into the CSF in the lateral ventricles or subarachnoid spaces. And then you measure what's happening in the CSF, in the arteries, and in the veins. And quite obviously, since this passes very poorly in the microvascular walls, the concentration in the CSF starts rising, but not in the arteries and the veins. So what they said, based on this, what they said is that within the ventricles, there is neither net formation of CSF volume, nor does it flow unidirectionally in the subarachnoid space. Fluid within the ventricles and within the brain are seamlessly moving and constantly moving between the brain interstitial space, the intravascular compartment, and the intraventricular compartment, because that is how easily water can move in these different spaces. So based on this, these studies, we now come to this new fluid balance model of CSF circulation. So what is this concept? What is this fluid balance and where is the balance between? So if you look at this picture, you can see the subarachnoid space communicates into the brain parenchyma by the perivascular spaces around the vessels which are penetrating the cortex. These are the Virchow-Robin spaces. These Virchow-Robin spaces communicate all along the vessels, go through the capillaries, venules, then out. And this space also communicates with the interstitial space in the brain parenchyma itself. And this interstitial space communicates in turn with the ventricular space. And CSF moves freely between all these compartments. And the balance between the amount of fluid in these different compartments is what leads to the different kinds of hydrocephalus, you could say. So is there more fluid in the ventricles, or is there more fluid in the subarachnoid space? Is there more fluid within the brain parenchyma itself? This balance between the amount of fluid in these different spaces is what leads to different kinds of hydrocephalus. So how was this elucidated? I mean, what made them think of this kind of a concept? This was based on a couple of studies. One is a very old one where Serre injected dextran blue 2000 into the caudate, and he found that there is intraparenchymal bulk flow of this dextran blue from the caudate into the surrounding structures through the interstitial spaces and the perivascular spaces. Then another more detailed experiment showed us more of this picture. This was done by Reynolds, where he injected horseradish peroxidase into the lateral ventricles or the subarachnoid space of cats and dogs. And as soon as this dye was injected, it immediately moved through all these spaces. So from the subarachnoid space, it went through the Virchow-Robin space, along the perivascular space, occupied the interstitial fluid, and similarly the other way around. So this rapid diffusion of this tracer was very quickly demonstrated. And the interesting thing that he found is that the pulsations of the arteries within the Virchow-Robin space was the main factor driving this diffusion. So if the heart rate was reduced, the movement of this dye slowed down. Increasing the heart rate increased this the rapidity at which this circulation happened, suggesting that hydrostatic force was very important in this circulation of CSF within the brain parenchyma itself. So let's look at this bit of that anatomical area in a little more detail. So what this is showing is the red is the blood vessel going into the brain. Surrounding that, you have the perivascular space, the Virchow-Robin space. And as the artery moves in, the astrocytic end feet sit around the blood vessels. And those astrocytic end feet are full of aquaporin 4 water channels. So CSF, which comes around, through the perivascular spaces around the artery, and any fluid which is pushed out by the hydrostatic forces from the artery into the perivascular space, is all freely able to move through the aquaporin channels into the astrocytes and then into the interstitial space of the brain parenchyma. So let's zoom this a little more and see what's happening. So on the left, you have the artery going into the brain parenchyma along with the perivascular space. And then you can see how the astrocytes with their foot processes are sitting on these vessels. And those small blue channels are the aquaporin 4 channels. The water in the perivascular space normally should flow freely through these aquaporin channels. And in the interstitial space, in the extravascular space, all the material which the neurons have ejected out as waste material, such as amyloid beta, which, if allowed to accumulate, would create problems for the brain, are pushed along through the brain, either by diffusion, which moves material for very short distances. And this fluid is then again pushed out on the venous side of the perivascular space. This venous side, at the venous side, all these abnormal waste material solutes are pushed out through into the paravenous space. Now, suppose you have a situation such as in Alzheimer's, where either you have the aquaporin channels are not working well, or in situations like arteriosclerotic diseases of the brain, you have the artery which is not pulsating properly. The arteries become stiff, and so there's inadequate pulsation of the artery. Then what happens is the fluid flow from the paraarterial space into the interstitial space and ultimately along the paravenous space reduces. So the amount of this movement of waste material like amyloid reduces, and these accumulate within the brain around the neurons and lead to conditions like Alzheimer's and multi-infarct dementia and things like that. Even situations like normal pressure hydrocephalus could have an element of this kind of poor circulation within the brain parenchyma, leading to cognitive impairment. So if, as I said, diffusion through the brain parenchyma itself is a useful mechanism only for small molecules and only for short distances. Whereas the distances which have to be traversed in the brain are quite lengthy, and from one cortex into the cortical venous sinuses, it could be quite a distance. So the other flow is through advective currents. These currents essentially are flow along the fluids, along the paravascular spaces, starting on the arterial side, going along the capillaries, coming out through the venular side, and all along out. So all along these spaces, you have movement of water. So on the arterial side, you have very high hydrostatic pressure. So CSF is being generated both by being pushed from the subarachnoid space and also by the hydrostatic pressure from the arteries. So these are generating fluid which flows along the vessels, taking with it large molecule which cannot move by diffusion. So all the waste matter moves along this advective current to reach the venular side. By the time it reaches the venular side of the circulation, the hydrostatic pressure has decreased. And in place, because fluid has moved out, the solutes within the vessels have increased, resulting in an increase in the osmotic pressure on the venular side. So you have a decrease in hydrostatic pressure and an increase in the osmotic pressure, because of which the fluid, the CSF in the paravenous spaces, gets pulled back into the veins, which then moves out into the dural venous sinuses, which they join. The solutes, on the other hand, which are in the paravenous sinuses, do not move into the veins. Instead, they move along this paravenous channels into the basal cisternal CSF areas around the dural venous sinuses, where there are meningeal lymphatics. These are also seen around the spinal nerves or the cranial nerves. The meningeal lymphatics around all these structures is where these solutes are taken and pushed out of the cerebral circulation. So that is how waste material is cleared through this system, which ILIF coined as the glymphatic system. And our current understanding of the glymphatic system is shown in this picture. And basically, as I described, you have the periarterial CSF influx, both from the subarachnoid space as well as from the arteries. Arterial pulsation is the pump which drives it forward. And as it moves through the capillaries in the brain parenchyma itself, you have diffusion and advective flow. All this material is taken, as you can see above, along the white matter tracts or along the major veins to the basal cisterns and then out through the lymphatics. So this is the complete picture of how the glymphatic system is one of the important ways in which CSF is being circulated within the brain, and current understanding could perhaps make this very important in the water circulation part of it. So once we understand this, we can hypothesize the following phenomena. One is that hydrocephalus is not an imbalance between CSF production and resorption, but an imbalance between interstitial fluid, which decreases, and ventricular fluid, which increases, while benign intracranial hypertension is the opposite imbalance. You have an increase in interstitial fluid and a decrease in ventricular fluid. So that explains one situation. But what about situations where you have tumor blocking the aqueduct? So in such a situation, the way to explain this would be that the hydrocephalus increases because of changes in the osmolarity within the ventricle, which has been obstructed, which pulls in more fluid and creates the ventricular enlargement. What about following subarachnoid hemorrhage? Here you have no obstruction, but the blood itself could be the reason why the intraventricular or subarachnoid fluid becomes hyperosmolar and pulls in more of the fluid. Or it could be because all this blood gets into the paravascular spaces, the interstitial fluid, thus obstructing this entire circulatory system leading to hydrocephalus. So this seems to explain quite a bit of what we understand about hydrocephalus. So is this alone adequate? Let us see. Then now we come to fetal, neonatal, and infant hydrocephalus. How is this different? So if you look at this graph here, you can see that in the embryo, the fetus, and the neonate till about 6 months, the purple arachnoid villi development graph is just a thin line. It's only after 6 months in the infant that arachnoid villi are starting to form and form adequately to be a site of CSF absorption. Prior to that, absorption is probably by the minor CSF pathway or the glymphatic circulation, which we were talking about earlier. Even choroid plexus is barely formed in the early fetus and only gradually starts forming later. So again, the CSF formation is seen much before that. So obviously this is from a source other than the choroid plexus and is primarily related to the ependymal secretions. So all this suggests that in hydrocephalus, which occurs within the fetus, the neonate and infancy, you have abnormalities which are likely to be predominantly within the minor CSF pathway. And the major CSF pathway, although it may contribute, is not such an important factor. So this is what DeRocco et al. Hypothesized in their evolutionary theory of how CSF dynamics and minor hydrocephalus should be one categorization, especially in the immature brain. So let's look at the ependyma. So during development, as the neural tube is folding upon itself, the neuroepithelium on the ventricular side which has tight junctions, start changing into ependyma. So they lose their apical tight junctions. They still have adherent areas along the sides. So laterally, the ependymal cells have interdigitating processes which are due to structural molecules within the cell membrane itself, such as N-cadherin. Also, the CSF side of the ependymal cells is polarized in such a way that there are cilia towards the ventricular side. Micro movement of this cilia is supposed to encourage CSF flow locally, change the concentration of substrates around the ependyma, and probably acts as a signaling mechanism. Also, this could be particularly important in narrower areas of the CSF pathway, such as the aqueduct or the foramen. The ependyma itself is also responsible for movement of fluid across this. So you have movement of CSF through aquaporin channels. So there are aquaporin 4 channels along the base of the ependyma, so towards the brain side. So the movement of fluid is from the brain side through these aquaporin channels into the ventricle. There are fewer aquaporin channels on the ventricular side of the ependymal cell. From the ventricular side, the movement is through pinocytosis, which is shown on the left side of this by the purple arrow. So those bring about movement from the ventricle into the brain and then into the ventricle, into the blood vessels within the brain parenchyma. So when this normal parenchyma is disturbed, as in suppose because of a genetic abnormality, you have failure of proper ependymal formation, the cells don't adhere to cell adhesion is not good, the polarity of the ependymal cells gets disturbed, then in all these situations, the disturbance of CSF circulation can lead to accumulation of fluid within the ventricles and hydrocephalus. The distorted ependyma, the damaged ependyma, can then get replaced by astrocytes, which is shown on the right side of this cartoon. And these astrocytes now don't behave similar to the normal ependyma. You can have movement of fluid in both directions along both in different pathways. The ciliary action is also not good. So all this leads to a situation where your ventricular movement of CSF is distorted and you have hydrocephalus, either due to genetic conditions or this kind of a reaction of can happen even with, say, intraventricular hemorrhage or trauma or things like that, which damage the ependyma. So based on these concepts, I'll tell you how developmental or congenital hydrocephalus occurs in various kinds of situations. So some of the common ways developmental hydrocephalus presence is X-linked hydrocephalus with congenital aqueductal stenosis. So this is a disorder associated with a gene mutation in the neural cell adhesion molecule L1-CAM, which is located on chromosome X. It's one of the most common genetic forms of hydrocephalus. And this glycoprotein L1-CAM mediates cell-cell adhesion. So it plays an important role in neural adhesion, migration, growth, and morphology of the neural cells, especially in the early developmental stage. This X-linked hydrocephalus is almost in 80% of patients is associated with aqueductal stenosis. Hydrocephalus ventriculomegaly is seen in 100%, but aqueductal stenosis is seen in about 80%. And along with this, you can have a situation called the crash syndrome, where you have corpus callosal hypoplasia, mental retardation, adducted thumbs, spastic paraplegia, and hydrocephalus. That's crash. The full CRASH is corpus callosal hypoplasia, CR is retardation, A is adducted thumbs, S is spastic paraplegia, and hydrocephalus. So this crash syndrome is seen in this kind of a scenario. Second, you have neural tube defects in spina bifida. So spina bifida is multifactorial, and hydrocephalus occurs in about 80% of these kids. And here, one of the mechanisms that is noted is that there's loss of the ependymal cell polarity and the ciliary beating. And this could be related to the genetic basis of spina bifida or to genes which are related to neural tube development itself. But of course, this is multifactorial, so you can't say that this alone is the result is causing hydrocephalus. Multiple. So, for example, you had in the MOMS trial, when you had fetal closure of the spina bifida neural tube defect, the number of children with hydrocephalus who needed shunts was reduced. So, how did this happen if it was exclusively genetic? But obviously, it didn't happen in all children. So that's why we say this kind of hydrocephalus is multifactorial. Multiple things may be affecting the development of this kind of hydrocephalus. Dandy-Walker syndrome is something which is associated with multiple chromosomal abnormalities, and there's no specific reason for this. And here this is characterized by hypoplasia and rotation of the cerebellar vermis upwards, enlargement of the fourth ventricle and the posterior fossa, and a rostrally shifted position of the transversinus, the tentorium, and the torcular hierophyllae. So there are again multiple mutations, as I said, so you can't pinpoint one specific reason why this happens. Holoprosencephaly is a brain malformation where you have failure of separation of the left and right cerebral hemispheres before neural tube closure. So this failure of separation can be partial or complete. And again, you have multiple factors which are causing this. So the primary ciliary dyskinesia and other ciliopathies again are related to the fact that the cilia on the ependyma stop working, and that results in some way to hydrocephalus in some patients. So as I said, if you look at this chart, the genes involved are numerous. So each of these conditions are related to multiple genes, except for the X-linked hydrocephalus, where you have only one abnormality. Or if you have posterior fossa crowding due to craniosynostosis, there that could be related to FR gene related problems. So with that, I'll close the discussion on the genetic part of things and come to kind of integration of all these things that we have discussed so far. So this is a very interesting paper by Ulrich Tomale, and he says that although each of these different theories that we discussed seems to be very interesting and promising and could answer many questions, all of them probably need to be integrated for us to have a complete understanding of how hydrocephalus occurs in different situations. And he described 7 factors which may be very relevant in hydrocephalus pathogenesis. And these 7 are what we have discussed so far. And one of them I'll have to still discuss, and I'll talk about it now. First one is decompensation of pulsatility. So yeah, pulsatility. Oh, you can't see my arrow, right? So let's look at it from 2 aspects. So you have non-communicating hydrocephalus, which he describes as the obstruction in the major pathway. This is at the top. Between those 2 red lines, you have obstruction in the foramen Monro, aqueduct, postventricular outlet, or in the cisterns. Then you have all the other reasons which are causing various kinds of what he calls as communicating hydrocephalus. So you remember I had told you how change in pulsatility within the ventricle can itself lead to hydrocephalus. So changes in the heartbeat or changes in the arteries within the brain could lead to this kind of hydrocephalus. CSF overproduction, that's obvious. You have increased CSF from the choroid plexus or the arterioles, and you have hydrocephalus. Then minor pathway disturbances and the glymphatic system that we talked about can lead to hydrocephalus by obstruction either at the cilia level, the aquaporins, the Virchow-Robin spaces, all these can get obstructed. CSF absorption disturbances can occur in the venules, in the arachnoid villi, in the lymphatics. Then CSF absorption, that is in the final outflow, in the veins, in the dural venous sinuses, or in the right heart. So if you have obstruction here, there is increase in pressure in these structures, leading to decreased venous outflow and buildup of hydrocephalus. Finally, we have respiration. Now, respiration is something which has not been very well studied in studies related to hydrocephalus. For one, because it's much more difficult to study, and 2, it's not so far techniques even with MRI studies have not been easy to control. It's not easy to control respiration and to look at the movement at that slow level. But some studies have started doing that. And what we now see is that within the spinal subarachnoid space, spinal CSF, you can see movement related to respiration. So during inspiration in the cervical subarachnoid space, spinal subarachnoid space, you have a net upward movement of CSF. And below the heart level is a net downward movement of CSF, with the area of the heart being the kind of center. And this whole thing is being driven by respiration through its effect on the epidural venous system, which acts as a kind of epidural venous pump. So this kind of movement, how does it reflect in hydrocephalus? So we are not quite clear how it influences hydrocephalus yet, but one thing is clear is that during inspiration, there is a small net upward flow through the aqueduct of CSF. And this has also been correlated with the net movement of CSF during endoscopic surgery. So when you watch the stoma, there is a net upward movement related to inspiration. So, but we still don't know how to fit this into the whole architecture of CSF physiology and how it is related to development of hydrocephalus. But further studies will perhaps elucidate this better. Finally, let me put all this together in this beautiful slide from the same paper by Ulrich Tomale, where on the top you have the various kinds of hydrocephalus. In the left vertical axis, you have the 6 important factors which control hydrocephalus. So you have pulsatility, CSF production, major pathway obstruction, minor pathway, CSF absorption, venous congestion. So let's look at each of these factors. So at the top left, starting with A, you have a situation of decompensated arrested hydrocephalus. Here, the main factor, which is shown in dark gray, is pulsatility. That is what drives this kind of hydrocephalus. But you also have a minor contribution by minor pathway obstruction. The next B is a choroid plexus tumor. In this, the primary driver of the hydrocephalus is CSF production, that's shown in the dark gray box, and minor contributions by pulsatility and the major pathway obstruction. So if you note, all the different kinds of hydrocephalus are in some way or the other affected by pulsatility. And various other factors are there. So now third is aqueductal stenosis, C. Third picture, you have aqueductal stenosis. Here it is a major pathway obstruction. Again, pulsatility is also playing a part in increasing the size of the ventricles, as we described earlier, how the pulsatile pressure increases and pushes the ventricle outwards. Then similarly, you have tumor obstructing the posterior fossa tumor obstructing the outflow pathway. So you have a major pathway obstruction, you have pulsatility, you have CSF absorption problem. That's because of the tumor materials which are being secreted, and you have venous congestion because you have tonsillar herniation, and that prevents proper absorption within the venous sinuses. Finally, then next you move on to, this is a cyst in the posterior fossa. So this large cyst, either in the retrocerebellar area or in the last image on the top row, that is F, you have a supracerebellar cyst. In both these circumstances, in the cysts, you have a major pathway obstruction. either the fourth ventricular outlet or the aqueduct in the second case. And then the other pathways are also involved. SB is spina bifida, which is the G panel to your in the bottom row, left side. So this is spina bifida hydrocephalus. Here again, major pathway obstruction as well as minor pathway, as I said, how the ependymal ciliary motion can be affected. Then you can have pulsatility, you can have venous congestion. All these are factors which could be responsible. Next, you have post-hemorrhagic hydrocephalus and post-infectious hydrocephalus. In both these situations, either because of the blood or because of the infection, there is a problem with absorption, both at the level within the brain parenchyma, as in minor pathways, as well as arachnoid villi, CSF movement through the subarachnoid spaces. At every level, absorption and movement is affected, leading to hydrocephalus. Then you come to K. K is subarachnomegaly. You remember I told you how when there is blockage or increased pressure within the venous dural sinuses, you can have subarachnomegaly in children who have open fontanelle. So this leads to the benign external hydrocephalus of infancy or subarachnomegaly. And finally, the last one is craniosynostosis. Craniosynostosis, you have a situation where the bone becomes tight at the outflow of the jugular veins, or the sinuses are narrowed, or you may have veins getting narrowed, all of which leads to venous congestion. In addition, because of the small posterior fossa, you may have a fourth ventricular outlet obstruction also. And pulsatility, of course, adds to the ventricular problem. So with this, we come to the end of the discussion, and I hope we've learned something. Part of it is related to how the pathophysiology of hydrocephalus is wide-ranging and often multifactorial. The classification based on this pathophysiology has evolved over the years, and we are getting a better sense of it. And the latest description by Ulrich Tomale tries to integrate all this and give us a better understanding of how hydrocephalus occurs and how this pathophysiology and classification can be used for better management. Yeah, with that, thank you. And I'll stop sharing now. Is anybody? Hello?
Yeah. I think you put an extensive, a complicated topic very eloquently and in detail. Now I'm looking at the chat box. I don't see any questions there. So how do you go about? You want to look at the self-assessment, or
how?
If there are questions, anybody can raise hands and they can participate. Or you want to take up the self-assessment?
But how many people are around? Like, how do we do that?
I see 23.
Like, how do they answer?
I see 23 on it.
23 participants, sir.
Okay.
Come down to 20. That is on 30 now, and then I think with time, we have been dropped out.
So if I ask a question, they answer in the chat box. But how do you analyze that?
Yes, that
or we can ask individual people, maybe. That
I don't know how many are there. That's a difficult thing, no?
Yeah.
Virtual, completely virtual.
Yeah.
Look at a question and you can, if no answer comes, no reply comes, we can discuss it. How many questions do you have?
No, what I've decided is for each of those slides, I can ask a question. So in relation to that. So for example, first let me ask, now you have the original concept of CSF circulation by Cushing. Can anybody tell me one experiment which proves that CSF is not actually circulating in the way Cushing described. Anybody can answer. You can can anybody unmute themselves, or what is the way?
If anybody wants to answer the question, any question, they can write in the chat box.
Let me see. I look at the. Oh, I've got some of. Madhusudan Bharadwaj is there. Chalo, Madhu, are you there? Or gone to sleep? Are they able to?
Shibu, I see in the chat.
Akash is put a message. Harsha, okay. Shantam Oreskovich, okay. So we have some answers, but is this a easy way to do it? Doesn't seem.
I think Shibu, this way it will be very difficult. Maybe next time we have the presentation, we can put some MCQs and we can evolve how to do it, because how can anybody speak and then in between? So it becomes a difficult thing to do it.
Yes, to interact like this is a little difficult.
Yeah, because you have to unmute everybody, then somebody will come up. So it becomes difficult for us to.
I think maybe we can have a MCQ round.
Yeah, maybe towards. I think the next time onwards we'll have a clear form where they can submit.
Yeah, or maybe the next time before the class they can do MCQ on this class.
Yes.
No. The simplest way will be that, like Shibu, towards the end of the talk, in your sharing screen, you can put the MCQs. And then the people can put the answer in the chat box. Now, and it's a self-assessment. They can find out whether it is correct or not.
Okay. Yeah. Fair enough.
Okay, I think Shibu.
Any other discussion? Any students want to ask any questions?
I think there's a lot of audio disturbance. We are not able to hear you clearly.
Ankita, can you put the disturbance? Ankita, can you? Shibu, can you see the chat box? You have a question there.
Okay.
Okay,
how can we differentiate? It's from Viren. I don't know. Full name is not mentioned.
Sorry to interrupt you, sir. There's a question to me directly, which is sent by Dr. Aditya Kumar. His question is: flow through the vessel ventricular interstitial space are balanced water flow. The question is okay. The question is incomplete. I think so, right, sir?
Ankita, there's a voice disturbance from Akash.
Yes, voice. Kindly please mute.
Can you mute it?
Yes, sir. I did it, sir. Okay.
Yeah, can you give the question? I don't see that in the chat box. Can you give us the question again?
How can we differentiate from a low pressure or medium or high pressure system of CSF flow? Because in some case, whatever may be the cause, if it's low pressure CSF system, then it requires multiple shunt revisions. Is it relevant in any way? Are you asking if the hydrocephalus is a low pressure hydrocephalus?
Can you,
is it important?
Dr. Piran, you can unmute yourself.
Hello, sir.
Yes, go ahead.
Hi, sir. This is Dr. Piran here. Just wanted to know the CSF pressure systems. I mean, like very well explained causes of hydrocephalus. But in this, sometimes when we see the pressure systems, it would be very low. Suppose in a patient with meningitis or post multiple shunt revisions, patients comes to us and they have we don't know the actual pressure. One it can be a low pressure system. Is that any way relevant to our treatment? Because we have seen once we put a medium pressure, then we see the CSF doesn't drain. Then we have to change it to a low pressure system. Then we see the CSF drains. It can be either through an EVD system or then finally concluding, then going in again. So that way it requires Is it in any way relevant, sir? Because we don't know what is the dynamics there.
definitely knowing the pressure inside is relevant, particularly say, for example, in a small infant with a open fontanelle, you have a growing brain, and if you put in a shunt which completely drains out all the CSF, you end up in a situation which can be quite damaging to the overall growth of the brain and development. You'll end up with slit ventricle syndrome, things like that. So you will need to adjust the outflow pressure to a setting which allows you a little more control. So even if though the pressure is low, you may have to adjust with either a programmable or some other kind of valve to a setting which does not overdrain, and you follow the trajectory of the head circumference and make sure it follows along the normal, at least relatively close to the normal trajectory. And as long as that is maintained, irrespective of the ventricle size, you should be quite okay. So you don't need to have a completely collapsed ventricle as long as the overall trajectory is maintained in such children. Now, in post-infectious, there are a whole lot of reasons why your shunt may not work, and it may not only be a factor of pressure. So it may be related to proteins, it may be infections, all kinds of things. So sometimes it can be quite tricky as to how to decide what exactly is happening in that particular patient. So I don't know if that answered your question. Any of the other moderators, if you have any other thoughts?
No, Dr. Piran, we'll have 2 more sessions on hydrocephalus, one on evaluation and one on management. So you will probably get more answers and you'll get a chance to think differently after those 2 sessions too.
Right, sir. Sure, sir. Thank you.
Yeah. So I'll tell you the whole scheme of things is like this. We want you to we want you to think. At the same time, the way you came up with the question, it was very good, and but at the same time, we'll cover up all the topics so that you are completely comfortable with the topic towards the end.
Right.
So 2 more topics remaining for hydrocephalus, and they'll come up as we go ahead.
Yes, sir. Thank you.
Is it okay?
Yes, sir. Thank you.
Through vessel, ventricle, interstitial space are balanced water flow. Okay, I understand. Aditya, you wanted to ask something?
So, wondering how it will explain other conditions like same balanced water flow model. How it explains like idiopathic intracranial hypertension and slit ventricle, those kind of pathology, how will explain with this hypothesis?
So, no, that's what I was trying to say with the last, the last concept of having an integrated approach to this. Each of these theories contributes one part of the puzzle, and different parts of it need to be taken together and put together, as in that last slide that I was showing you. So each pathology may have one main cause and multiple sub causes. So every problem is like that.
Okay.
So benign intracranial hypertension, like I was saying, is, so suppose the dural venous sinuses pressure rises. So then you have a backup within the venous system. And within the venular side of the intraparenchymal system, the hydrostatic pressure starts going up. Okay. The water from the paravenous space goes into the veins because of a low hydrostatic pressure and a high osmotic pressure within the veins. Now, when the back pressure leads to a higher hydrostatic pressure within the veins, the amount of paravenous fluid which can enter the veins reduces. So this leads to a buildup of intraparenchymal water. And that is what I was saying. So interstitial fluid increases, interstitial fluid pressure increases, and that leads to a condition of idiopathic intracranial hypertension. So that's similarly, other things can be explained along these similar lines. So each of it, there is part of the problem is answered in one way or the other, but multiple areas may be affected.
Okay, sir.
That explains it.
Shibu, you have a question in the chat box by Dr. Akash.
If the flow of CSF from periarterial space to perivenous space is guided by pulsation in arteries and osmotic gradient in venous channels, then what is the role of aquaporin 4 in both these areas? So aquaporin 4 is actually related to the astrocytic food processes around the vessels. So as I said, there are two ways in which water is flowing. One is around the vessels, which is advective flow. The other is movement of water through the neuron itself and through the interstitial space. And this is influenced by the aquaporin 4 channels. Aquaporin 4 channels are also important in the movement of water at the ependymal end of things also.
Ms. Ankita, can you unmute Dr. Pooja?
Sure, sir. Sure.
I think we'll take about 2 more questions and then we'll stop. Shibu?
Yeah, okay.
Okay, so I would request Dr. Pooja to click on the button because I have sent her a request to unmute herself.
Dr. Pooja?
So, Dr. Pooja, you're requested to click on that button, which I have requested. Yes, ma'am.
Pooja, go ahead.
No, sir, I didn't ask a question.
Okay,
Oh, you raised your hand accidentally, huh?
No, accident.
Okay.
Shibu, what do you say? Should we?
I think shall we close then? Any other burning questions? Any comments from the moderators or anything else you need to add?
Yeah. So,
yeah, I think Shibu, it was a very, very exhaustive talk, and I think you collaborated the entire traditional theory along with the new theories. I think still the pathophysiology of hydrocephalus has not been fully understood, but you have tried to put across all the possible causes and the clinical conditions we see. And I think, thank you, Shibu. I think you've put in a great job.
So only one question for all the audience. Now, while Suhas and I were discussing, our idea was to be as complete as possible. Obviously, that means we are going to be talking for a long time. So I don't know if that is the right way to do it. Or should we keep it shorter? Should we restrict it?
So Shibu, what
you can put your comments in the chat box and then we'll have a look at it later.
No, at the same time,
the audience who's still there, just you can.
What we will do is we will send a Google survey form to all the participants, and we on how to improve it, how to modify it, or how what all things to add up. This being an initial program, of course, some things we are picking up. We'll modify it in the next time. Is it okay?
Problem is, not many answer the Google forms. So if you can just tell now, only it'll be easy.
Yeah, but yeah.
Was it too long? Just say yes or no. Too exhaustive, too long.
I think this Shibu, it's a complicated topic. Doing justice to this in a very short time is not a good idea. But at the same time, it tests a tolerance of the listeners too. That's okay, but that's not okay. I mean, the topic is a complicated one. It needs extensive. I think from here onwards, all the topics will be there in the website. Even this topic would be there in the website and the Clarinet website. Both the websites have the links. So anybody who wants to go back to the session will freely be able to do it in detail. And of course, the same, we will do it with all topics that are going to come up. It will be there on both sides. Beyond that, how to keep the topics and the sessions, we are yet to decide. We will come up with that. So the next program is planned for, as a standard plan is there. We have the sessions would be on the last Sunday of every month. Presently, the time is decided at 7 to 8. We can modify according to the Google survey or according to feedbacks, which you can send it IndSPN.gmail@gmail.com. And the next program is planned for April 29th. Regarding the self-assessment too, we will modify how to go ahead with the self-assessment so that it's useful for you. What else? I think the next topic that is planned is clinical and imaging evaluation of hydrocephalus. Sounds okay? Is that okay, Shibu and Naveen?
Yeah, sounds good.
Yeah, I think sounds good.
Yeah. Ankita, can we, is it okay if we can close? Yeah.
Yes, sir. Thank you everyone for sharing your valuable insights. We are more than grateful to everyone present here. We hope to have you again on our platform very soon for your next session. So with all your permission, we are concluding the session over here. Okay, sir. Thank you everyone. Good night.
Good night. Thank you. Thanks for listening.
Google survey to be returned at the earliest.
Thank you so much, sir. Good night, sir.
Good night. Thank you. Thank you, Shibu. Thank you, Naveen. Thank you. Good night.
Thank you. Thank you. Thank you, Suhas.